A patient arrives in the emergency room with crushing chest pain and ST segment changes on their ECG. How should this patient be managed? That's the subject of this tutorial. An introduction to critical care, presented by me, your host, Pat Nelligan. Heart attack. Part 2. Acute coronary syndromes. In the previous tutorial, we looked at myocardial ischemia, what it is and why it happens, coronary thrombosis and the evolution of myocardial infarction, myocardial injury and the ECG, myocardial geography and the ECG, and myocardial infarction arteries and the ECG. In this tutorial, I will discuss the diagnosis of myocardial infarction, the management of an ST segment elevation, MI, the management of a non-ST segment elevation, MI, and myocardial infarction in the ICU and why it's different. Let's look at the clinical scenarios that I introduced in the previous tutorial. The first patient was Sean, who presented with crushing chest pain radiating up into his jaw and down his left arm. He was cold, clammy, and diaphoretic. He had ST segment elevation on his ECG with a raised troponin. His ECG revealed an ST segment elevation myocardial infarct. He requires the urgent attention of an interventional cardiologist. In acute MI, you may also encounter a new left bundle branch block, such as in this example, making ST segment changes difficult to visualize. Or as we've seen before, the MI may affect the inferior wall, in this case with lateral and posterior wall extension. The second patient was Angela, who felt weak and unwell, and alongside an elevated troponin, she had T-wave inversion on the inferior leads of her ECG. Isabel is 76 years old. She is post-op major surgery and she's in the ICU. The nurse notices new T-wave inversion on the monitor. An ECG is performed and there is T-wave inversion on the anterior leads of her ECG with a raised troponin, a heart rate of 100 and blood pressure of 100/65. This is an example of an ECG that would look like Isabel's. It's important to understand that although Isabel's ECG looks a bit like Angela's, the clinical circumstances are different. Isabel is still undergoing a major perioperative stress response and has developed these ECG changes while in hospital after having had surgery. Angela came from the community. So let's talk about acute coronary syndromes. Acute coronary syndromes are a spectrum of conditions that are caused by sudden interruption in the blood supply to the heart. The ultimate diagnosis may be unstable angina or acute myocardial infarction. That may be an ST segment elevation, myocardial infarct, or a non-ST segment elevation, myocardial infarct. Both of these are type 1 MIs and they are usually associated with atherosclerotic events. Myocardial infarction is defined as cardiomyocyte necrosis in the clinical setting of acute myocardial ischemia. It is the end point. The current definitions of myocardial infarction come from a consensus conference in 2018, the so-called Fourth Universal Definitions of Myocardial Infarction. Summarizing these definitions, we start with clinical evidence of myocardial ischemia characterized by elevated cardiac troponin. Be aware that troponin accumulates in acute kidney injury, so a high troponin does not always mean acute coronary insufficiency. There should be at least one of the following: clinical symptoms, chest pain, discomfort, or shortness of breath. New ECG changes, ST segment changes, a new left bundle branch block or T-wave changes, pathological Q waves, imaging evidence such as echocardiography, MRI, or coronary angiography, demonstrating loss of myocardium or wall motion abnormalities, and identification of the coronary thrombus either during angiography or, God forbid, during autopsy. Cardiac troponin is the quantitative marker of cardiomyocyte damage. The higher the level, the more likely myocardial infarction is taking place. If the troponin is elevated by 5 times the normal reference range, there is a 90% positive predictive value for acute type 1 myocardial infarction. Type 1 meaning coronary thrombosis. Now, there is a second type of myocardial infarction known as type 2. Type 2 myocardial infarction is a flow demand problem. In this example, there is initially good flow, and that matches demand and supply is good. Subsequently, the flow falls, but the demand remains the same and ischemia results. This is a supply side problem. Conversely, in this example, the flow looks okay and oxygen is extracted, but because of increased demand, oxygen levels plummet along the length of the artery and ischemia results. This is a demand side problem. So type 2 myocardial infarction is caused by reduced myocardial perfusion or increased oxygen demand or both. And we see this in all kinds of situations such as coronary artery spasm, coronary artery embolism, coronary artery dissection. But in the ICU, the most common causes are hypotension, bradycardia, or tachycardia. And that is seen in any form of shock, for example, septic shock or hypovolemic shock or severe anemia where there's low oxygen delivery. It is part of acute critical illness. It's also sometimes seen in myocarditis. So looking at our patients, Sean and Angela both are having type 1 MIs and need immediate cardiology assessment for percutaneous coronary interventions. Isabel probably has incurred a type 2 myocardial infarct associated with stress. Let us now look at the management of acute coronary syndromes. The principles of management include identification of ST segment elevation MI or non-STEMI, then opening the vessel, keeping the vessel open, and protecting the heart. What I'm going to go through now is a brief and very simple summary of the contents of the 2023 European guidelines for the management of these syndromes. The lead author on this document was Professor Robert Byrne of the Royal College of Surgeons of Ireland. Acute coronary syndromes represent a clinical spectrum including unstable angina, non-STEMI or STEMI, and the same basic approach applies to all three. You suspect an acute coronary syndrome, do an ECG, consider the clinical context and examine the patient. Destination is destiny. If the patient has an acute coronary syndrome, they need to be transferred to an interventional cardiac unit as soon as possible. When they arrive at that unit, they should have invasive coronary angiography, again ASAP, and that is recommended for a ST segment elevation MI or a non-STEMI with high-risk features, and they include hemodynamic instability, cardiogenic shock, ongoing chest pain refractory to treatment, acute heart failure, life-threatening arrhythmias, or cardiac arrest. In terms of opening the vessel, the first thing that should be done is to anticoagulate the patient, and all patients with acute coronary syndromes should receive anticoagulation. For a STEMI, dual antiplatelet therapy is given. That includes aspirin plus a P2Y12 receptor antagonist. Now, these are also known as adenosine diphosphate receptor antagonists, ADP antagonists, and the most commonly used versions of these are ticagrelor and prasugrel. There is an alternative, that's clopidogrel. I'll get back to that in a couple of minutes. If the patient has a non-STEMI, then we will give the patient aspirin PO or PR, and we will wait for a cardiology opinion. The patient shouldn't get dual antiplatelet therapy initially. In ST segment elevation, myocardial infarction, STEMI, as soon as you see that ECG, and if it's a compelling diagnosis, dual antiplatelet therapy, DAPT, is given by the emergency room physicians before interventional cardiology even sees the patient. If it's a non-STEMI, then the second anticoagulant is withheld until the coronary anatomy is known, unless there's going to be a big delay, because you need to take into account the bleeding risk and alternative diagnoses. A loading dose of aspirin, 325 milligrams, is given to both. At the time of percutaneous coronary intervention, intravenous anticoagulation is given. That's heparin or a low molecular weight heparinoid. If there is a delay in PCI in non-STEMI, then one usually would give a low molecular weight heparinoid such as enoxaparin or fondaparinux. Once the decision is made to do a PCI, regardless of the situation, P2Y12 receptor antagonists are administered. In the country I work in, that is ticagrelor, but the European guidelines suggest you use prasugrel, and you can look up yourself the differences between the two of these drugs. Alternatively, clopidogrel can be given particularly to elderly patients. This cartoon is from the European guidelines. It illustrates the different areas in which the system is anticoagulated, remembering that the P2Y12 receptor is different from the receptor, the thromboxane receptor that aspirin works on. So these are two different approaches to stopping platelets aggregating. What about opening the vessel and keeping the vessel open? The vessel can be opened using fibrinolysis, such as TPA, but these days the standard of care is percutaneous coronary interventions, angiography plus PROCEED. The anatomy can be defined, the culprit artery identified, and angioplasty and stenting performed. If symptom onset is less than 12 hours, primary percutaneous coronary interventions, angiography, angioplasty, and stenting should be performed, and this should be done within 60 minutes if a patient arrives at a 24-hour PCI center. And if they arrive in another hospital, it should be done within 90 minutes. And that's why in my hospital, we have helicopters arriving from all over the west coast of Ireland, bringing patients with this problem to our center. In terms of non-STEMIs, many non-STEMIs are associated with sepsis, cancer, trauma, etc., and may not benefit from PCI. So the patient should be transferred to a PCI center for evaluation. If it's a confirmed diagnosis, there are dynamic ST segment changes, transient ST segment elevation, or a GRACE risk score of 140. That is a risk score that looks at 8 different variables: age, heart rate, systolic blood pressure, creatinine level, whether the patient has congestive heart failure, whether there's ST segment changes, whether the patient has a cardiac arrest on admission, and the level of elevation of the cardiac biomarkers. Anything over 140 is considered high risk. What about multivessel disease? Sometimes when the patient goes to the cath lab, they see the culprit artery that's causing the MI, but there's a whole bunch of other arteries with severe disease. The current best evidence supports complete revascularization, whether it's a STEMI or a non-STEMI. In the past, they just did a staged PCI of the non-infarct related arteries, aiming to have complete revascularization within 45 days, but that is not how it's done now, with one exception, and that is in cardiogenic shock, as proven by the culprit shock trial, where revascularization of the culprit vessel alone was shown to be associated with better outcomes. For patients resuscitated following cardiac arrest with persistent ST segment elevation on ECG, primary PCI should be performed. If the patient is hemodynamically stable without persistent ST segment changes, PCI should not be performed. Subsequently, dual antiplatelet therapy should be given for 12 months, and that involves the P2Y12 receptor inhibitors plus aspirin. The duration and type of therapy can be modified according to bleeding risk and probably should be personalized. Inflammation is a major part of acute coronary syndromes and coronary arterial disease, and colchicine is an anti-inflammatory agent that we associate with gout, but it seems to have an emerging role in secondary prevention. So it should be considered if optimal therapy is in place and there are recurrent cardiovascular events following unstable angina or PCI. Let's go and revisit Isabel. Remember, Isabel had major surgery and she's in the ICU. We see this type of picture quite frequently. The nurse sees new T-wave inversion on the monitor. There's T-wave inversion on the anterior leads of the ECG with a raised troponin. This, of course, is type 2 myocardial ischemia, and it involves inadequate oxygen delivery to the myocardium to maintain homeostasis, and it's either a problem of demand or supply or both, as we have seen early in this tutorial. It's a common complication of the flow phase of the stress response, whether that stress response is adaptive, perioperatively, or maladaptive, for example, in sepsis, and it's rarely associated with conventional plaque rupture and thrombosis, although thrombus may be present due to the hyperthrombotic state that we see in acute critical illness. How should Isabel be treated? Aspirin is probably warranted, but other antiplatelet agents may increase the risk of bleeding with little benefit, and they should be withheld. It's important to look holistically at the patient. Check the fluid status. Both overload and under-resuscitation may increase the risk of infarction. In a post-operative patient like this, where the heart rate is high, the blood pressure looks normal, it's important to look at causes of stress and a hyperadrenergic state, such as severe pain, a full bladder, anxiety, etc. Beta blockade may be considered to reduce myocardial oxygen demand, for example, the use of an esmolol infusion. But you need to be aware of two major clinical trials, POISE and POISE-2. POISE was an enormous clinical trial of more than 8,300 patients in 190 centres in 23 countries, published in The Lancet in 2008, and patients were randomized to receive metoprolol before surgery and for up to 30 days post-op. This was non-cardiac surgery in moderate risk patients. Although there was a 1.5% absolute risk reduction in the risk of myocardial infarction, that's a number needed to treat of 66. There was a 0.8% absolute increase in the risk of death, a number needed to injure of 125, and a 0.5% absolute risk increase for stroke with a number needed to injure of 200. With these numbers, most patients would choose not to be beta blocked. POISE-2 was a second huge trial published in the New England Journal in 2014, including 10,000 patients in 135 centres in 23 countries, and two trials were done. One was aspirin and one was clonidine. The dose of clonidine was 200 micrograms per day, PO or transdermally. These patients were also having non-cardiac surgery. The aspirin trial included 9,000 patients, and giving aspirin perioperatively showed no difference in cardiac risk, but there was a slight increase in the risk of major bleeding, absolute risk increase of 0.8%, number needed to injure of 125. The clonidine trial was much smaller. There was only just over 700 patients in the trial, but clonidine increased risk. It caused clinically significant hypotension, almost 10%, with a number needed to injure of about 10, and more scarily, was associated with non-fatal cardiac arrest. Now, the number was quite small. The risk increase was 0.2%, but a number needed to injure of 500. So for every 500 patients who got clonidine with no evidence of benefit, one patient had a cardiac arrest. And I think that should make you think twice about injecting clonidine into your perioperative patients in the belief that it has some kind of adjunct analgesic effect in this patient population, high-risk patients undergoing major surgery. Isabel will not undergo immediate angiography. Studies to date have shown no benefit of angiography and potential PCI in this scenario. That's a periop type 2 MI. However, it's imperative that the patient is carefully assessed for potential type 1 MI, particularly if there is known coronary arterial disease. In general, if you're in a non-cardiac center and you have a patient like Isabel, it is not necessary to transfer her to a cardiac center because she's not going to get interventional therapy. If the patient is hypotensive and vasoplegic for any reason and has been fluid resuscitated, then you must give a vasopressor with alpha and beta adrenergic effects, not phenylephrine. What follows is a drawing from an illustration from a pharmacology book burnt into my memory decades ago. I'm going to draw a series of lines in sequence: systolic blood pressure, mean arterial pressure, diastolic pressure, and myocardial oxygen consumption. We are now going to give the patient noradrenaline, norepinephrine. Note that the systolic, mean, and diastolic blood pressures all increase. The myocardial oxygen consumption does not change. That is a really good scenario for the patient. Perfusion pressures increase, and as norepinephrine is a coronary vasodilator, so too does flow. As heart rate does not increase and inotropy is enhanced by increased perfusion, there is minimal impact on myocardial oxygen demand. Supply increases over demand. So this is the agent of choice in the setting of type 2 ischemia and indeed cardiogenic shock. What about adrenaline? Epinephrine. It's a fight or flight agent. It increases blood flow to the brain and skeletal muscle where it works as a vasodilator. Adrenaline has powerful chronotropic effects. It increases heart rate alongside inotropy. When we give adrenaline, we see an increase in systolic and mean pressures, but a slight decrease, remember, the muscles, in diastolic pressure. And myocardial oxygen consumption increases, principally driven by tachycardia. So this agent, adrenaline epinephrine, is not ideal in the setting of a type 2 myocardial infarct or myocardial ischemia. In my opinion, if you have a patient at high risk for perioperative MI or with a type 2 MI in ICU, they benefit from not being allowed to be anemic. So ensure that the volume status is appropriate and transfuse the patient to a hemoglobin of 10 grams per deciliter. Ensure that pain and anxiety are adequately addressed and epidurals are good. An old study from 2001 suggested that an epidural analgesia reduced the risk of perioperative MI, although in modern anesthesia practice, paravertebral, thoracic, and abdominal wall blocks are emerging as good alternatives, particularly with regard to patient mobilization. Avoid vasodilator drugs, but continue beta blockers and statins if they were being delivered to the patient preoperatively. Treat vasoplegia with norepinephrine. Let's review this tutorial. In this tutorial, I discussed the diagnosis of myocardial infarction. I went through the management based on the most recent consensus guidelines of ST segment MIs, of non-ST segment MIs, and myocardial ischemia in the ICU and why it's different. Next time, we're going to look at cardiogenic shock, the mechanisms of cardiogenic shock, and how it's treated. I'll see you then, and I guarantee you'll learn something. Well, that was the management of acute myocardial infarction. Next time, we are going to look at cardiogenic shock, the causes of it, why we see these patients in the ICU, and how it's managed. I'll see you soon.